Well, good afternoon again. This is the Medical Advisory Committee, our run review section for NorCal EMS. This is our November 2014. I've got some fun cases, and let's get started without further ado. Okay, so case one, call type was a 91-year-old woman who fell. Never a good thing when you're 91. Most things, I think, when you're 91 probably are not good. These are cases I did take from Santa Clara, so the FACEP and route times will be very different than NorCal. So FACEP time, public safety answering point, was called at 1938. Ambulance had an excellent shoot time, 1938 en route. 5 minutes to get to the scene. They're at the patient 2 minutes later, and then 17 minutes later they depart the scene. They arrive 6 minutes to the hospital, and they were on scene for a fair amount of time before releasing the patient. Pretty straightforward so far. So, primary impression trauma, ground level fall, although you have to wait in the PCR later on, it doesn't say initially. This woman's chief complaint was right hip pain for 2 hours. She denies any allergies to any medications. Her only medication is Synthroid for her hypothyroidism. I hope I'm that healthy when I'm 91 years old. Actually, I hope I'm still alive when I'm 91 years old, or something like that. Okay, so case one continued. In 1945, they started their ALS assessment. Normal for the mental status is normal for the patient. Confused. This was the family members were present. She was oriented to person, place, and events. Evidently not time or date. Neuro, the paramedic documented as normal. Well, it's not. If the patient's confused, neuro exam isn't normal. Again, it's the danger of a drop-down box with limited choices. They did document, however, speech was normal. Eyes were reactive. Chest, lung exam, normal assessment. Breath sounds were clear and equal bilaterally. Abdomen non-tender, normal. They said she had no tenderness to her cervical, thoracic, or lumbar spine. No pain, no deformities. Again, their documentation on her extremities were all, normal and positive capillary motor and sensation. I find it hard to believe if she's complaining of right hip pain that her exam is normal in that extremity. Again, the dangers of not changing a drop-down menu whose default is normal. So her vital signs, 1945, GCS of 14, initial blood pressure taken 13 minutes later, right arm, they did document which arm, that's good, 163/81, heart rate 97, she's a little tachypnic at 18, room air oximetry was good at 98%. That's actually a little unusual because usually by the time you start getting up into the 90s, normal SaO2 probably has dropped down from 96 to 98% to probably somewhere between 90 and 92%, just normal decrease in lung function. She's complaining that her pain is a 10 out of a 10 scale, I'm assuming. They did do a stroke scale, and so her speech was normal. Her arm drift was normal or negative, and she had no facial droop. Again, when you do the arm drift, you need to make sure the palms are up and the hands are together to watch whether there is a drift or not. That's one of the really common mistakes I have seen made during my ride-along time, is when they do the arm drift, they just have the patient stick their hands out and they don't have the palms up. So in 1945, they did their ALS assessment. Spinal assessment, they said no deficits. They did put her on a cardiac monitor. reasonable because she is 91. And why did she fall? Did she have a syncopal episode? Did she have chest pain? Or did she just trip and fall? They did a venous access at 2003, 18 gauge. Unclear whether they hung an IV, or as we've really been we've been asking everybody to do a saline lock. And I think that's something we can probably do in NorCal also, particularly with the saline shortage, although I haven't heard much about saline shortage recently. You never know when that's going to come back. And we did a very nice little study in Santa Clara, and out of 85% of the IVs that were started, only 150 cc's were used on any of the liter bags because they were all at TKO. Here at 2003 they did document it, although, here it says 18 gauge at 2003, and the other one says 20 gauge. Not sure which it was. They gave this 91-year-old 5 milligrams of MS. We unfortunately in Santa Clara don't have fentanyl yet. We're fortunate in NorCal to have fentanyl. So here's the narrative. So they found this woman alert and oriented ×3, GCS of 14. She was sitting upright in a chair complaining of right hip pain and right arm pain. Again, if you go back to the evaluation, it says all extremities normal. So not only did she have right arm pain and hip pain, but they documented it initially as normal. Poor form.
He also did the blood pressure on the arm that hurt.
Correct. So, patient states she was walking through her house when she tripped and fell on her right side and hit her head. They did ask, at least here, and the patient denied a loss of consciousness. She was able to recall the entire event. She denied chest pain, shortness of breath, easy for me to say, blurred vision, or headache. No dizziness. Well, you got to be very specific with the elderly what dizziness means, because many times it's not real clear, particularly if you're dealing with a syncopal episode. Here, you're not. She remembered the entire event. She denied any nausea or vomiting, any abdominal pain, or recent illness. Abdominal pain is a good thing to ask in the 91-year-old. Do they have an aneurysm causing them to pass out? She denies feeling weak. I'm sure that's probably everybody's, one of a lot of people's pet peeves. I feel weak and dizzy. Very difficult in the emergency department. You probably find the causes of, quote, feeling weak maybe 50% of the time. Most times you never do. Patients just not able to recall the year or the month. Not bad for 91. Although, per the family, they say that she normally knows the year and the month, so they made her a trauma because of the potential head injury, because she was not 100% oriented. Normally she is. And she denied any change in the pain after the MS was given. So, let's discuss the care. Do you think the care was appropriate for this 91-year-old?
Yes.
I have one yes. Kara is a big sigh. Kara has some issues, it sounds like.
So ground level fall and you make her a trauma?
She hit her head.
What's her age?
91.
No. And what are her meds? Is she on aspirin or Plavix?
Synthroid.
That's it?
That's it.
I don't think I'd make her a trauma.
Yeah,
They
but
make it a trauma alert?
Yeah, they made her a trauma.
they made her a trauma alert.
Which means you're going code 3 with this patient?
That's correct.
No,
I wouldn't do that, but.
I wouldn't have done code 3. I wouldn't have called it a trauma alert. I would have said she has a head injury.
Well, she went to a trauma center and they'd make her a trauma alert.
And she hit her head, but her head assessment was normal. Didn't have any lumps or bumps or bruises or bleeding.
Well, that's because they just did the drop down normal. you really don't know, because in the PCR it does say she complains of head pain. So you really don't know, because the documentation was less than stellar.
It
So
doesn't say that they even C-spined her in the narrative.
I'm sure
And I
they
hope they didn't.
no, they did not do.
Okay, if you don't C-spine them, why are you calling it a trauma alert?
Because the only thing that I can think of is for the potential head injury. However, she was hemodynamically.
Whoops.
Well, in the time frame, she did it 2 hours ago, right?
Yeah,
I mean,
that's
our
correct. That's
connection.
what it said. 2 hour. She had a fall 2 hours ago, and she was sitting upright in a chair talking. So yes, she could have head injury, but
Right. It's not an epidural.
it's not a trauma alert. It doesn't meet trauma triage criteria in anything that I can think of, other than
Paramedic judgment.
decision.
So they made this woman a trauma alert. I'm not sure whether I would have, but again, provider discretion. Fortunately, they did not C-spine this 91-year-old, because I would have thought that would be cruel and unusual punishment.
Okay, ready? Protocol. Head injury. Altered level of consciousness currently requires full spinal mobilization per your protocol.
Plus her age.
Per your current protocols, she has to be C-spined. Because she has a head injury with an altered mental status. And a fall. And 91. She has to be C-spined. But you're saying it was appropriate. I agree it was appropriate. But
Not
I'm just
to
saying
C-spine.
it doesn't meet protocol.
Thank you for stirring.
Yeah, it's selective. It's still, there's still the judgment piece to it.
Well,
There is no judgment in our current protocols.
and not in the current protocols.
In the new ones, there will be, I know that.
Right. So what do you think went well?
They evidently got an IV and gave her some pain meds, but it didn't help. But they only had it for a
Short period of
it was a
time.
short transfer, so probably wouldn't have gotten, I doubt that 5 milligrams of morphine probably would have been the best starting point anyway, so. And they probably wouldn't have dumped a whole bunch in a short transport.
Right. I mean, but there were some things that they didn't document.
Did they reassess the patient's blood pressure after the pain meds?
No.
They didn't document any shortening, rotation, anything
Ah!
like that.
Thank you. They didn't document any external rotation, any shortening. They said it was
They
normal.
never said any deformity.
No pain on palpation.
No pain on
They
palpation.
just, or crepitus or anything else, they just said she steadied, it hurt.
Right. So you're correct. Their documentation was poor. Recommended changes to protocols. We're working toward the selective spinal immobilization. Does everybody have the link again? Can they see it?
Yes.
Great. Okay.
This is Renee. I don't have it yet.
Okay. Yes, Mr. Lane. Mr. Lane is holding up a piece of paper saying 65 years of age.
Well, I tend to agree with that, with 2 hours of the incident happening and 91 years old with an altered level of consciousness.
All I can tell you guys is the literature clearly recommends, according to the Canadian C-spine rules, that these people, and I'm not sure, I'd have to go back and look at the nexus criteria, that people over 65 are at higher risk.
But you said
But
that
apparently
you were happy that they didn't C-spine this lady.
Yep,
But then you would have been breaking your own
you're correct.
and could have gotten written up. And
But I'm not I'm an independent practitioner. I think Mr. Lane's going to stab me with my own pen at the moment. Okay, I will take it under advisement. Damn, I hate when he's right. It really bugs me when he's right. Okay. Any other questions except for Mr. Lane?
This is Bob from FRC again. It goes back to that age determination and, having a healthy 70, 80, 90-year-old person that might not need to be C-spined, but with the current policy that's written now, if it's 65 or over, and with signs, you're going to throw them on the board.
Okay. I will consider it. I can listen. Barely, but I can listen. Okay. So, Renee, did you get the new link yet?
No, I still don't have it.
Well,
I haven't gotten it either.
Things travel slowly today.
things are not moving quickly. Well, let's go on to the second case. Case 2, the call type was abdominal pain in a 6-year-old male. PSAP time, 1852. En route time, 1853. They were at scene at 1901, so 8 minutes later. They're at patient's side at 1905, 4 minutes. They're,
What took them so long to get to the patient? Do we ever say?
No, they do not. And it's hard to tell from the PCR on the address whether it's a private residence or apartment complex. I asked the same question. They depart at 1915. They're on scene 10 minutes. They arrive at destination or the hospital 16 minutes, 21 minutes, sorry. Eesh. And then they were hanging around for about 14 minutes before they released their patient and somebody assumed care. So, what are people thinking? Belly pain in a 6-year-old.
Happy.
Okay.
What was it, trauma? Let's find out a little bit more.
We have one person thinking happy.
Trauma or not?
Trauma. Anything else?
Arthritis. Where does it hurt? Where does it hurt at?
Okay.
FOS.
Oh, we have one full of stool. Okay. Ever the optimist, Mr. Balbione. Okay. So, primary impression, behavioral, psychiatric, and then the chief complaint is chest discomfort for 10 minutes. There's a little disconnect there. I don't know whether they just clicked on the wrong drop down. I'm really not sure what happened. No known drug allergies, no medications, and no past medical history to mention.
Maybe the kid's faking it. That's why they put behavior psychiatric.
Maybe.
Kind of young.
And the answer,
6-year-old.
if you go back, it said they were dispatched to abdominal pain, but that's just what somebody told the 911 operator. It doesn't really mean that that's what.
That's how I document too. So if I have to bring it to court later, okay, I was
Dispatched to.
dispatched to this, but this is what I really found.
Right. Okay. Good points. So at 2020, physical exam, mental status, normal for patient, alert and oriented times 4, neuro normal, lungs normal, breath sounds were equal and bilateral. Again, the left upper quadrant is documented as normal, non-tender. The left lower quadrant, again, is documented as normal, non-tender. Right upper quadrant, normal, non-tender, and right lower quadrant, normal, non-tender. So, did they just assume the drop-downs were normal? What did this kid really have? We'll probably find out more in the narrative. Back is normal. So that makes me think less, if it really is truly normal, then you're not thinking pyelonephritis in a kid. Kidney stones in a 6-year-old, unless they got something congenital going on, highly unlikely. Same thing for a urinary tract infection in a young male. They probably, if they do, they have vesicular ureteral reflux, meaning the urine is backing up into the collecting system. Again, not the most common. So, 1905, GCS of 15. They did take a temperature, much to their credit, 37 normal. Blood pressure of 90/69, right arm. Pulse rate a little elevated at 120. Respiratory rate a little elevated at 24. Kid's probably pretty anxious. SpO2 of normal at 100%. Not clear whether this was room air or not. They didn't document that. 1918, pulse rate of 132. And then later on they documented a blood pressure, which I find really hard to believe, at 1923 of 140/97. There's something wrong there.
Medicine come in and crying.
I'm sorry, what?
Was a kid
Is
crying?
the kid being emotional at this time, crying, and any distress? Or is that in the narrative?
It is not in the narrative, I can tell you that much. Yes, Mr. Lane.
That's an automatic blood pressure machine, and they didn't bother to take a look, and the kid was probably going like this, and
Mr. Lane raises a very valid point. It was probably an automated blood pressure machine, which I don't like, and his arm was more than likely flexed, and they weren't paying attention. Pulse rates come down a little bit from the 132 earlier, but still 125, a little elevated. So the kid's either in pain or anxious.
and if you'll notice, within 6 minutes, the respiratory rate went from 24 to 11.
Yeah, I don't quite buy that either.
Yeah.
Um,
How do you get an 11 in
Well-
respiratory rate? Have you ever come out with an odd number?
If I count for a minute, maybe.
Yeah, I'm sure they did.
Yeah, they more than likely counted for 10 seconds and multiplied if they, never mind. So again, Mr. Lane
They did 15.
was very good, and he said 11. I find that hard to believe. So, responded code 2 for report of a male complaining of abdominal pain. They were first on scene, the ambulance, performed an ALS assessment. The patient complains of chest discomfort and a, quote, funny feeling in his hands and fingers. Well, I know where I'm thinking right now. Is this kid hyperventilating? Patient's family states that the patient has been, quote, yawning, and that the patient states he cannot yawn and get the air out. I'm not sure what that really means. I have, to be honest with you, does anybody else have an idea what that really means?
Sometimes you just document what people tell you and what, just to get how crazy they really are.
Yeah, well, this is a 6-year-old. He's getting practice early on.
Yep.
Is there a language barrier?
No. Patient was alert and oriented times 4. GCS of 15. Good. Skin signs pink, warm, and dry. And the family denies that he's been ill recently. Interestingly enough, they asked the mom whether the patient had consumed alcohol or any medications. It's interesting they'd ask about alcohol. They loaded this 6-year-old in the ambulance, continued to monitor them. Lung sounds were fine. Breath sounds were equal bilaterally. Pupils were equal and round, reactive to light. No allergic reaction, no hives, and the mom says no similar episodes in the past.
See, but that last statement, mother denies to her knowledge that the patient patient consuming an alcohol. Okay, whatever. So basically, mother didn't deny, but just denies it. I don't know whether he did or not.
Interesting documentation. And if there's grammatical errors, I don't correct them.
I know, okay.
So, do you think the care was appropriate for the 6-year-old?
What they did.
Is it the protocol response code 2 to something like that?
Yeah, code 2 is fine. I don't think they really did anything for the kid other than ALS assessment.
What was the kid's level of pain?
Well, they never documented level of pain.
And it didn't say he had the pain. He just said he had, if I remember,
It was chest discomfort, actually, per the kid.
yeah, my chest feels funny and that my hands are tingling or whatever.
Right. So,
QRST, you know, what provoked it?
yeah, they didn't document very well.
Pain, no.
You know, as Kara said, what provoked it, what made it worse, what was the quality, what made it respond.
Nausea, vomiting, diarrhea,
Oh,
They
intake,
gave,
output.
they gave the general impression as anxiety behavioral, right? Or
that was what I
behavioral-
got from it.
Behavioral or psychiatric. Unfortunately, if they're using image trend, at that point, they wouldn't be able to write anxiety as a possible thing, but that would have been appropriate if that's what they're treating this as an anxious kid who's made themselves go into carpal pedal spasming because of rapid breathing and hyperventilating and anxiety. They should have put that into the narrative to
Right.
better define that.
What Mr. Lane just said, for those of you who couldn't hear it, is that it sounds like this kid was having some carpal pedal spasm, and that they should have documented, if they were thinking that this was anxiety, in the narrative. That's very true. The other thing they should have documented in the narrative is, did this kid have any GI symptoms like diarrhea, nausea, vomiting? Did he have a cough? I've seen plenty of kids who have had pneumonias who come in complaining of belly pain because pneumonia is resting on the diaphragm. Mr. Lane was pointing to his finger frantically and saying, was this a new onset DKA? And no, they did not do a blood sugar on this kid, which they should have done.
But they did not document, or they documented that the abdomen was not the problem. Even though the dispatch was dispatched as an abdominal problem. They didn't say that it was.
Right.
So, and they said the abdomen was clear. Now,
Correct.
I don't know about you, Tony, but I usually don't say our dispatcher was wrong,
No, I don't say that.
or the dispatch information was off the wall or incorrect or anything else. I just generally say we were dispatched to this, but the patient was complaining of this when we got there. Or what, not quite using that word, but basically then saying what the patient was complaining of, just like they did. So, at least where I work, our dispatcher are not EMRs by any close, even, probably can't even spell EMR or know what that is, so therefore the dispatch information isn't always correct.
Well, that's okay, because even in Santa Clara, where they are all EMD certified, and County Communications, which is the biggest, is an ACE center, which is a level of accreditation and excellence. A lot of times what they get dispatched for and what they find are true and not related. So, what do you think about the care?
So they were, so abdominal pain versus chest pain, did they document breath sounds?
Yes.
Yes.
Yes, okay.
They documented breath sounds were clear
And equal.
and equal.
Oh, app sound.
No, they didn't document that. Like a spontaneous pneumo?
To be honest with you, with what they wrote, the care was probably okay. I mean,
Yeah,
The kid probably was not going to die anytime soon. And it sounded like when they put that behavioral, psychiatric, or whatever as what they wrote as the problem, their impression, that it sounds like this kid was just,
acting out.
I'd like to see some particular assessment, like, okay, we assess this kid, he's anxious, we gave comfort measures, and it helped or didn't, the patient's got pain, we treated it, position of comfort, whatever, reevaluation. So, assessment, treatment, and reevaluation.
Yeah, I'd like to see that too, assessment, treatment, and evaluation too.
Yeah. Even if it's just a little, even if it's just comfort measures or position of comfort.
Right, they don't mention any of that stuff. And what they do put in the narrative is okay. It never really says, was it a respiratory, was it behavioral, or was it GI? So they really never make the distinction between whether it was an organic cause or behavioral. They just don't. What went well, I think that the kid got transported, and I think the kid would have done fine, although the kid was tachycardic and tachypnic for 6. 6-year-old with a respiratory rate of 24 is a little fast. Let's go back and look at the vital signs.
But then again, we don't know whether that was anxiety or, what was the kid's affect during that time.
The other thing that worries me is this.
erroneous.
You think it's an erroneous or spurious blood pressure, the 140/97?
One of the two are.
One of the two.
If I had a choice,
They go down with their list.
I'd say the 140's wrong.
Go on.
I think it goes along with their documentation on the respiratory rate at 11. That's suspect as well with the 140/97. Did they get sloppy with their recording their notes?
You want my honest answer? Yes. Many times when I pull these charts, I do give the paramedics who treated these patients feedback. Okay, let's go on to case number 3. Call type, unknown, 20-year-old female. At the FACEP level, 1859. En route, same time. They arrive at scene 7 minutes later. They're at the scene for a while though, 25 minutes. Again, short transport, and their patient gets released from them to the ED 12 minutes later. So, primary impression, neck pain. Chief complaint, neck pain secondary to vehicle accident 44, not 43 and not 45, but 44 minutes ago. Okay, I'm being snide and I shouldn't be. Allergies are to sulfa. Medications are none. Past medical history, none. So vehicular injury indicator, intrusion greater than 1 foot, and estimated speed greater than 55 miles an hour.
So how old were they again?
20.
With a sulfa allergy?
And she had Bactrim for a UTI.
And they responded to a residence?
This was highway.
Oh, highway, okay.
So how long did it take them to get there? 7 minutes.
Oh, it's a female.
7 minutes.
But the accident was 44 minutes before they got there.
Correct.
So it took 30 minutes to notify PSAP?
Evidently, because they found her in the car. I just write the stuff as I find them. I don't make, I don't editorialize until now. So the physical exam, mental status normal for this patient, alert and oriented times 4, Neuro is normal. Eyes are reactive. Neck, we'll find out. It says normal, but it isn't. Chest and lungs, normal assessment. The abdomen is normal, soft and non-tender. Thoracic is normal, no pain, no deformities. The separate physical exam, the extremities were, quote, normal. Head and face, they've got pain and tenderness, but I don't know. We never find out where the pain and tenderness of the face is. Cervical, they have pain, but no mention of numbness, weakness, or tingling. Lumbar, they have pain, and again, no mention of numbness, weakness, or tingling. So all we know is they have
So
pain.
Pain is normal,
Well, they didn't say, if you notice, they didn't say,
neck is normal.
right, they contradict themselves. This is
Okay.
real common. This is one of the downfalls with electronic PCRs
Drop down menu.
and drop-down menus.
And where you don't have any other option for what's,
Oh, they do, but it takes an extra step.
Yeah, all you gotta do is not click anything and then fill in the blank at the bottom.
Correct, Tony. All you need is not click on normal and you can fill things in. So, all we know now is they've got pain and tenderness to their face, cervical and lumbar spine hurt. That's it. So their GCS is normal. I'm not sure why at 1907 there was a GCS and they don't document any vital signs until 1926.
simple, if she was in the car, wait until they get out of the
Yeah,
car.
did they have extrication or?
No. Blood pressure,
They were on scene for almost that long.
right. They didn't have to extricate her though. At least they never mentioned it.
So they didn't.
But I'm not I don't stop and take a blood pressure when a patient's in the car when I'm working to get them out, so. And
Okay.
especially if they're talking to me and they're fairly pink, warm, and dry and everything else, I know they got a blood pressure.
Would you get a heart rate?
Yeah, probably.
So the heart rate's 93, respiratory rate, at least a little tachypnic for 20. She's anxious, she's allowed. SpO2 of normal, room air. They did a glucose, it was normal. They repeat the vital signs, not significantly different. The pulse rates come down some. They did put her on a monitor, showed normal sinus. They did a saline lock 18 gauge, that's fine. And you can see when they did the glucose analysis.
I mean, out of order there, huh?
Okay, go back up, Doc, real quickly. The reason they took so long to get the vital signs is because they're using an automatic machine, because the monitor and the blood pressure are all at the same time.
Okay.
Which is normal.
Mr. Lane feels that the delay is they're using an automatic machine, and that's why you get the blood pressure, the heart rate, and the respiratory rate all at once.
And that's also why you're getting the odd numbers, because if you're palpating blood pressure, auscultating blood pressure, you're going to get the even numbers.
Correct.
Unless you're really good and you know that it just like fell right in between those two
Yeah,
little
oh,
lines.
shit.
I mean,
Yeah.
when I had really good eyesight, I could do that, but
I don't believe that, but okay. So, let's onward and upward. They were dispatched to a vehicle and found a 20-year-old woman, third row of the vehicle she was in, on the freeway, with fire assessing her, who was involved in a motor vehicle
So
accident.
the fire was involved in the motor vehicle accident? I'm sorry, grammar.
Again, I don't correct grammar, spelling, or syntax.
Okay.
I just transcribe it. The patient is a restrained passenger in the third row on the right side of the SUV with airbag deployment with 1 foot intrusion into the passenger compartment from the rear of the SUV that was stopped on the freeway and rear-ended by another vehicle going 50 to 70 miles per hour. She was placed in a cervical collar and placed in manual spinal precautions. Patients extracted out of the SUV and placed in spinal precautions.
That's why,
I think I'd be more worried about the people who went in the car that hit her, going 50 to 75.
that's why they didn't get a blood pressure for a while, because yes, they had to put her in C-spine and all that stuff.
Thank you, Mr. Lane. So the patient's carried onto the stretcher via backboard and loaded into the ambulance. The patient complains of midline neck pain, lower back pain, and right face pain. That's about all they could get. It's like, okay. Patient has dizziness, headache, nausea, vomiting, numbness, or tingling. But where on her face does it hurt? She's transported as a trauma center code. She's to the trauma center. She's a trauma patient. Code 2.
Yep.
And en route, they start an 18-gauge saline lock, and they checked her blood sugar. She denies any chest pain, shortness of breath, dizziness, or headache.
Whiplash.
So, what do you think went appropriate? Was the care appropriate? I'm thinking, yeah.
Under current protocols are those that I'm sure they had, she needed to be C-spine because she had the neck and the back pain, and she was in a vehicle accident that was hit fairly fast. I'm glad they didn't code 3 her because she wasn't in any significant.
So,
She wasn't ready to crash.
no, she clearly wasn't ready to crash. Mr. Lane's saying that he's glad that she was code 2, that she wasn't ready to crash. What went well? I think it's just a generic call that needs better documentation. That's what could be improved, their documentation. Where on her face did it hurt?
Would it also be significant if there was other patients, on scene? I mean, if
Yes.
it's an MCI,
There's no mention of the other patients.
you know, so if she was in the third row, what about the other people
There
in the
was
car?
nobody else in
What
the
about
car.
other car? And she was driving from the third
Yes.
row? That's cool.
I want to see driving from the third row, Mr. Lane.
She's in the WNBA.
She could have been just sitting, they were stopped, maybe she stopped on the side of the road and everybody else was out of the car. We don't know. And is there airbags in the third seat? Because it said the airbags were
Yeah.
They
deployed.
were on the
Which
side.
airbags?
The airbags on the side.
Side airbag.
Doesn't, are you assuming
Okay,
that?
you can't assume it.
It said that, side airbags.
No, it said airbags deployed.
Oh, I thought it said side.
No.
No,
Go back,
Which airbags are
go
deployed?
back.
I have no idea what airbags were deployed.
If the steering wheel airbag was deployed, that doesn't mean diddly squat to the person in the third row. I mean, okay, it makes some difference to the fact that there was something tripped in the car's
Right,
system, but that doesn't mean a whole lot either.
correct.
to-
So
To this patient.
the documentation again is lacking. So yeah, they could improve their documentation. Do I think the care provided was fine? Yes. Was the documentation fine? No. So, onward and upward. Call type, seizure, convulsions in a 2-year-old male. So the FACEP is 9:38, en route a minute later. At the scene, 10 minutes later, at 9:49. At the patient side, 2 minutes, and they were there for 10 minutes. Destination, 1 minute. They must have been right around the corner.
11 minutes.
Oh, sorry, 11 minutes. I'm dyslexic today. Thank you for keeping me honest. 11 minutes, and then they were there for 12 minutes. There we go. So, chief complaint, seizure for 2 minutes. The kid has no allergies, no meds. Interesting, though, is the kid's got a seizure disorder, diagnosed with fetal alcohol syndrome, which has got its own host of issues. And the seizure, first time was last week, and they were not given a final diagnosis. Interesting enough about kids with fetal alcohol syndrome, they don't look normal. They have thin upper lips, the bridges of the nose, very flat. I would recommend Googling and taking a look at what some of these kids look like. It's hard to describe, but they clearly don't have normal facial features. The other thing is, there was a nice little study that I found out of Medscape, and it was about, let's see here. Yeah, in one study, they said that 95% of the people who have fetal alcohol syndrome end up having mental health issues. Along with this is confinement in prison, drug or alcohol treatment center, or mental institution was 55%, trouble with the law was 60%, inappropriate sexual behavior was 52%, inability to live independently was 82%, problems with employment 70%, and alcohol and drug problems 50%, greater than 50% for males and 70% of females. So alcohol clearly is not benign during pregnancy. So the kid, again, normal for patient. I'm not sure how a 2-year-old is oriented to person, place, time, and events. This is just sloppy documentation. Neuro is normal. Well, probably not. There's probably something else going on that they're just not seeing. Eyes reactive, yeah, I can believe that. Skin normal, I can believe that. Head and face normal, no. These kids and adults, don't have normal facial features. So they just defaulted, which is very sad. Neck is normal. Lungs, I can believe. Abdomen, unremarkable. The cervical, thoracic, and lumbar spine, fine. The extremities, all were normal. Interesting enough, also about these people, they're very short stature. They did a separate lung exam again at 10:05. It was normal. They did do a GCS. They said 15. I find it hard to believe that a 2-year-old would have a GCS of 15. If the kid's upset, postictal, I would think it'd be better to say alert, verbal, purposeful movement than GCS. They did do a blood sugar, which was normal, and that's good. Temperature was normal, again good. Blood pressure was normal, 99/75, a little narrowed pulse pressure. Kid was a little tachycardic, even for a 2-year-old at 142. Respiratory rate a little fast. Room air oximetry is fine. They repeated the blood pressure, that actually makes more sense. Pulse rate better. And then the respiratory rate at 26. Sinus tach. The interesting thing, though, is prior to arrival, fire first responders put this kid on oxygen by mask for 15 liters. And so, when was this done? Did they just take this, because they said the SaO2 was 100% on room air. When did they take the mask off? Was that 10:02? 10:01? At 10 o'clock? So, arrived on scene, private residence, 2-year-old sitting in foster mom's lap, no apparent distress, fire at the side. Patient's alert and oriented to baseline. That's real helpful.
Yeah, what's that mean?
Your guess is as good as mine. Again, I just transcribed this stuff. I was on a particular rant and picked lots of cases that the documentation was not that great. Per the Guardian, he was sitting on the couch, was about to fall asleep when he was witnessed to have this full-body tonic-clonic seizure. and it was followed by some focal arm activity. Obviously, he was seizing a straight stare the entire time, remained pink, warm, and dry. So this may even have been like a Jacksonian march, and so it's really hard to tell exactly what type of seizure. Probably why they didn't give him a definitive diagnosis last week when he was seen. They did ask about first seizure. There are no accidents, injuries, medical procedures. They did ask about fever, cough, cold, nausea, vomiting, or diarrhea. Patient was afebrile, which was good,
But they didn't mark the temperature.
but they didn't mark the
How do we
temperature.
know it was afebrile?
I have to take their documentation for it.
No, it said he did not suffer from a fever, cold, so they asked somebody.
They took a temperature. It was 37.
What's
They did?
PGL?
Blood glucose. Oh, you're right, they did.
Okay, sorry, missed that.
Sorry, thank you, Tony. I missed that. And the blood sugar is 109. So patient was afebrile, blood glucose level within normal limits. Code 2 transport. So, think the care was appropriate?
They did everything.
I don't really have that huge an issue.
Well, I'm glad that they checked the glucose.
I'm glad they checked the
And
glucose.
Yeah.
At 2 years old,
Yeah.
you should be checking glucose and temperature,
Right. And they did both.
and they did both. There's not much they're gonna do for seizures unless, of course, they started an IV in case he went into having seizures. Do they have anything to give for medications for seizures down there?
Yes, they do. Ativan, Valium, and Versed.
Okay.
So they can give any one of the three.
So, and why don't we? You did,
We have 2 of the 3.
I know. Is there a reason they didn't have an IV then? It's a 2-year-old, and I'm not a big fan of trying to start IV.
Kid wasn't actively seizing. I don't think I necessarily can fault them. They can do a MAD.
Mad if they needed to.
Correct.
Meds.
They could do a mucosal atomizer device if they needed meds.
Rectal valve, right?
MAD would be better than rectal. Rectal's tough in a seizing kid.
Yeah. I never know what size needle to use in the
Ouch.
syringe.
We have rectal in our protocol, though.
Yes, we do.
Yes, but without a needle. For Mr. Lane, I would use a
Doesn't
new.
say that.
Thank you, Mr. Lane.
I like that they documented that during the seizure, the kid remained pink.
Mm-hmm.
I think that's important, because a lot of times, during a seizure, a kid's gonna get a little bluish around the lips. And I
Right.
like that they asked that and documented that.
I think that was really good. This was probably the best call of all.
Yeah. Well documented, you mean?
Well documented, correct. Anybody have any other questions, comments, or concerns about the call?
No?
Okay.